Hello and welcome. Everyone, first of all, I would like to apologize for the delay. It's due to some technical issue, and thank you for being patient with us. So hello again and welcome to our EBAC accredited webinar from the ISCP A to Z of CV Pharmacotherapy series. Today's program will be focused on Valsartan Sacubitril with our title, Has Our Paradigm Shifted? Hi, my name is Janice. I'll be your moderator for today. I'm currently working as a clinical pharmacist in Sarawak Heart Centre, Malaysia. And I have Professor Doreen Tan from National University of Singapore together with me to moderate the program or session today. Hi, Prof. Doreen. And it is indeed a great pleasure that we have a fantastic faculties joining us today. So first of all, I would like to introduce our honorable speaker, Professor Giuseppe Rosano. Professor Rosano is a professor of cardiology and consultant cardiologist at St. George Hospital NHS Trust, University of London. Welcome, Professor Rosano.
Yeah.
Next, I'll move on to our panelists for today. First up, we have Dr. Richard Henry Tiongco. Dr. Tiongco is currently a director at the Philippine Heart Association. He was chair in the past for 2 councils and was immediate past chair for the Council of Cardiovascular Pharmacotherapy. Welcome, Dr. Richard.
Pleasure.
Last but not least, we have Prof. Rungroj Krittayphong with us. Professor Rungroj Krittayphong is a professor of medicine and head of the Division of Cardiology, Department of Medicine, Siriraj Hospital, Mahidol University in Bangkok, Thailand. Welcome, Professor. Okay, Today's broadcast is supported by International Society of Cardiovascular Pharmacotherapy and brought to you by Radcliffe Cardiology. This is to be an interactive session, which will feature a 10 minutes live audience Q&A segment. So please feel free to submit your questions to the faculty via the question modules on the web page. And we will try our very best to answer as many of them as possible. So without further ado, I would like to hand over the time to our Professor Rosano, who is going to be presenting on Valsartan Sacubitril. Has our paradigm shifted? Professor, please.
Thank you very much, and thank you for having me. As we know, the new guidelines suggest a fast initiation of the 4 foundation therapies in patients with heart failure. And if you look at the ESC guidelines, you can clearly see that there is a dualism of where we suggest ACE inhibitors or ARNI, and ARNI are suggested are a substitution of ACE inhibitors when patients are still symptomatic despite full dose of an ACE inhibitor. And this is in line with the finding of the landmark study that was the paradigm HF. But in order to understand why we have an approach that has kept the ACE inhibitors first line, is that we need to understand how the study was designed. The study randomized more than 8,000 patients with heart failure and reduced ejection fraction. They had to be tested. First of all, they had to be on enalapril 10 milligrams BD and able to tolerate it. Then they were started on a run-in phase with sacubitril valsartan that was up-titrated to 200 milligrams, and they had to tolerate it. And then if they tolerated, then they've been randomized to receive either enalapril 10 milligrams or sacubitril valsartan. And during this randomization phase, during the run-in phase, 30%, nearly 30% of patients discontinue their medications because of several reasons. So basically, patients have been randomized. There were patients who had already been tested and have been tested and were able to tolerate the background medical therapy. Furthermore, the study included patients with New York Heart Association class 2 and 4, but it was mostly 2 and 3, with an ejection fraction that initially was set as less than 40%, but actually then it was less than 35%. They also needed to have raised NT-proBNP or BNP values, and they should have been able to tolerate and be on a stable dose of enalapril 10 milligrams. So you can see that there were very selective criteria for the inclusion of the study that are very important for the external validity of the results, and also they had to be they had to have a eGFR greater than 30. As you know, the results of the study were very positive, with a 20% reduction in the primary outcome of mortality and hospitalizations for heart failure, with a reduction in significant reduction in hospitalizations for heart failure. And this was a 20% that equaled a number needed to treat of 21. When they looked at the hospitalizations for heart failure, there was a significant reduction both in the number of patients, with a reduced number of hospitalizations, so patients hospitalized with sacubitril valsartan, but also a reduced number of admissions. So it was not just the first admission, but the second admission for heart failure that was reduced by sacubitril valsartan. But then when we look at the external validity of the results, we can see that although there was no heterogeneity among the different subgroups, you can clearly see that the patients who benefited most were those patients with a left ventricular ejection fraction less than 35%, but also those patients who had received prior an ACE inhibitor, while those patients who had not received an ACE inhibitor before had less of an effect. So you can also see that the effect was mostly in class 2 and 3. It was in those patients who received the ACE inhibitor, but what is important, it was also constant across all the different subgroups. So at the end, the finding of the study was a positive study where sacubitril valsartan reduced the risk of cardiovascular death and hospitalizations, reduced cardiovascular death by 20%, reduced the risk of hospitalizations by 21%, and all-cause mortality by 16%. But in ambulatory patients with chronic heart failure, elevated natriuretic peptides, able to tolerate enalapril 10 milligrams BD, and with no history of angioedema or RASI-induced cough. So that is important because that is what is in the European Medicines Agency recommendation for use, and is in line with the recommendation of the ESC HFA for sacubitril valsartan. So should we give, the question raises, where should we give sacubitril valsartan in all patients with heart failure and reduced ejection fraction? Our indication and our guidelines suggest to give it in symptomatic patients despite being on a treatment with an ACE inhibitors, beta blockers, and MRA, that they either can tolerate the 10 milligrams of enalapril or equivalent ACE inhibitors or ARB, and also that they have elevated natriuretic peptides. Then after the Paradigm HF, another study, that was the Pioneer HF, tried to explore the possibility or the feasibility of starting sacubitril valsartan in sicker patients with heart failure. What is important is that Pioneer HF study was not a study to assess the effect of sacubitril valsartan on mortality and morbidity, was only designed to look at safety, initiation of use, and the effect on natriuretic peptides. The study demonstrated that sacubitril valsartan in patients who were weaned from infusions and still hospitalized was effective in reducing NT-proBNP more than enalapril. However, we have to ask how relevant is the NT-proBNP change in patients with heart failure, And we know with from studies with, for example, alixaquiran, where they've shown a very significant reduction in NT-proBNP, that if anything, this was associated with a neutral effect or an increased risk in patients with heart failure. So we cannot really extrapolate from changes in NT-proBNP the effectiveness of a medication that is given at this discharge. Also, when we look at the comparing the two trials, we know that in PARADIGMA-HF, there was a suggestion that the patients had less hyperkalemia, less deterioration of left ventricular of renal function over time, whilst the Pioneer basically showed the opposite. I mean, there was no effect on worsening renal function, an increased risk of hyperkalemia with sacubitril valsartan. So we have two studies with different findings, especially on renal function, and therefore, despite the fact that they've suggested a potential benefit on endpoints, the authors clearly stated in the paper that the results had not been adjusted for multiple comparisons, and therefore these results cannot be extrapolated to as an effect. And indeed, after the trial, we had another trial on mortality and morbidity, that is the Paradise MI. These were not necessarily patients with heart failure, but they were patients with left ventricular dysfunction after an MI. And in this case, sacubitril valsartan was compared to ramipril, and no difference between the two treatments was detected. Another issue is that in PARADIGMA-HF, looked at patients with mostly class 2 and 3 heart failure. You can see that patients with class 4 were only less than 1% of patients included in PARADIGMA-HF, and therefore the LIFE-HF study looked at exploring the effect of sacubitril valsartan compared to valsartan, in this case, on NT-proBNP and events. As you can see, the LIFE-HF did not show any significant difference between sacubitril valsartan and valsartan on NT-proBNP change, but also did not demonstrate any difference in cardiovascular death or heart failure rehospitalizations with sacubitril valsartan compared to valsartan, that in this case had a lower event rate. Now, for this very reason, when we wrote the recommendations for the treatment of patients with a heart failure and reduced ejection fraction, we kept a class 1A for an ACE inhibitor, beta blocker, MRA, and dapagliflozin and empagliflozin. These are the 4 foundation therapies. Then in patients who continue to be symptomatic despite full dose of ACE inhibitor, then it's possible to use sacubitril valsartan in order to further reduce the risk of hospitalizations and death. Now, what about preserved? Now, we have overwhelming evidence today that for preserved and for mid-range, we have to use the SGLT2 inhibitors. After the results of the liver and Emperor preserved, there's no question on whether the SGLT2 inhibitors should be used. Sacubitril valsartan was tested against valsartan in patients with preserved ejection fraction. The study was negative, as it was there was no difference between sacubitril valsartan and valsartan. And although there were some suggestions that the sacubitril valsartan may work on in patients below the median left ventricular function, that was 56%. Statistically, you cannot draw any sub-analysis from a study that is negative. So the study should be regarded as negative, and for this reason is not included in the recommendation for sacubitril valsartan was not included in our guidelines where it is a 2B indication. So in conclusion, when we face a patient with an ACE inhibitor, should we always start with an ACE inhibitor, or should we consider sacubitril valsartan? The recommendation is to always use an ACE inhibitor except for those patients who have a symptomatic heart failure and reduced ejection fraction, despite guideline-recommended therapies that are able to tolerate ACE inhibitor equivalent to enalapril 20 milligrams, or for those patients who have been hospitalized with heart failure and reduced ejection fraction who are already receiving an ACE inhibitor equivalent to 20 milligrams of enalapril. And in that case, we can switch. For preserved ejection fraction, we still have a class 1 that should come soon, indication for the SGLT2 inhibitors. And these are the drugs that should be used for preserved, whilst all the other medications should be given according to the different profiles and comorbidities that we have in preserved ejection fraction. Thank you very much for your attention.
Thank you, Professor Rosano. And this is Doreen. Thank you, Professor Rosano, for giving us that very brief oversight of what Entresto can do for our patients. Before we go into our case discussion, I'd like everyone to remember to post your questions into the Q&A box at the bottom of your screen, just so that we could address your questions and answer later on. I'm sure you're burning with questions to ask Professor Rosano about what he thinks with respect to the Paragon studies. All right, I'll hand the time over to Janice. Janice, would you like to take over with the case?
Yeah, sure. Thank you, Doreen. So now let's move on to the first real-world cases, which is Madam W.A.J. She was 59 years old. She was admitted with a diagnosis of acute decompensated heart failure and AKI, which is acute kidney injury. She was a non-case of diabetic mellitus type 2, hypertension, dyslipidemia, and also a heart failure with reduced EF. So from the history, we can see that she has a multiple hospital admission. First, it's in October 2020, where she was first diagnosed with heart failure with reduced EF, and less than a year later, which is in April 2021, she has a second admission for the same diagnosis. And this year, in 2022, she was admitted again. So for the current admission, her echo finding that her ejection fractions was 40% in 2020, and unfortunately, it has further reduced to 35% in 2021 and 2022. And for this admission, we ran her NT-proBNP level, and it was turned out to be 3,520. And her BP actually throughout the ward stay was acceptable, and her heart rate was fine. So some of his views and creatinine finding here, which we should take note, is that his creatinine was slightly above the normal, and his creatinine clearance based on the Cochran-Gault calculation is range between 35 to 37 mils per minute. And also to note that his potassium level was still within the normal range. When he's out of failure and was stable, then she was discharged with the following medications. She was discharged with tablet bisoprolol, 10 mg once daily, tablet empagliflozin, 10 mg once daily, tablet spironolactone, 25 mg once daily, and tablet furosemide, 40 milligram once daily, and also tablet allopurinol, 150 mg once daily, tablet pantoprazole, 40 mg once daily, and tablet vildagliptin, 50 mg once daily, and last tablet atorvastatin, 20 milligram at night. So from this discharge medication list, you can see that she was not put on ACE or ARB or ARNI. So for the first question I would like to ask is that how would this patient's treatment plans to be optimized? And Professor Rosano, do you have any opinion on this?
Well, of course, this is a patient that should be started on a RASi inhibitor, and of course, keeping a close look at the renal function. But we say clearly in our guidelines that even if you have an initial decline in renal function with an ACE inhibitor, you shouldn't be stopping and should be continuing.
Yes, that is very true. But I believe in the real world setting, a lot of us, when we see the creatinine clearance with such a number, 30 to 35, we will be start to shaking our hands and saying that, oh, should we or should we not to be put on ACE or ARB? But obviously for Professor Rosano, the answer is yes, the patient need to be on ARNI. Am I correct?
On an ACE inhibitor, I would start. I mean, we run a clinic with a nephrologist, and we have a renal clinic regularly. And you cannot imagine how that is helpful, because the nephrologist can push your ACE inhibitors much more up to the limit with very confidence and give you confidence. And that is according to the guidelines, because also the guidelines say that if you don't have more than 50% change, then that there's no problem.
Oh, well, I think this really gives us a great confident boost for all the clinicians later on, that if we see such a number, yes, it's fine to start ACE or ARNI, but I believe the monitoring part, we do need to be a little, a little bit more frequent, I would say. So how would you suggest for the monitoring part?
It depends on the frequency and of up titration that you want to set up. But usually you should be doing a week and then 2 weeks and then a month. And this is also in line with our guidelines that suggest that patients should be seen at 1 week after the hospitalizations, and then thereafter 2 weeks and 1 month.
Oh. Elegant answer by Professor Rosano. Janice, I think there's a question about the evidence of starting an ARNI de novo and a patient who's not already on ACE and ARB. I think Prof. Rosano had addressed that earlier. I wondered whether the other two professors, Ricky or Rungroj, you have opinions?
This is Rungroj. I believe that this is a kind of a debate issue that some experts propose that ARNI can be start first without SCI at the beginning. And I think that the guideline both for ACC and ESC has changed that give us the room for the option using ARNI even before ACE inhibitor. And the issue of afraid of angioedema, something like that, from ARNI is become less concerned, since there's some clinical trial that start ARNI first, and there's still not much complication. But I think Professor Rosano also give a option that we should begin with ACE inhibitor. But I think that is flexible. This is my opinion. And also another point of starting ACE inhibitor or ARNI in patient with creatinine clearance around 35 is that you should have the optimal volume status. You have to make sure that the patient is not in the step of increasing dose of diuretic or something like that. Sometimes if you just changing the dose of diuretic and you start ACI or ARNI, you have a good chance of having creatinine clearance running down. This is the practical point. Thank you.
Thank you for the good reminder, Professor Rungroj. I think there was another question about how in the ESC guidelines in 2021, the ARB has disappeared from the guidelines. That was quite an interesting way of putting it by the person who asked the question. I personally feel like the ARB has not disappeared because it's actually found in the sacubitril valsartan combination in that sense. I wonder whether Ricky has a comment to make about that.
Yeah, I mean, for us,
Oh, Giuseppe? Go ahead.
I mean, the reason why we put as a second line is because, first of all, we use it very, very little. And you can see in the European registries, almost 95% of patients use ACE inhibitors. I understand that there are sometimes in Asia you tend to have more cough. I mean, this has not been always clearly assessed. It's more in patients with hypertension than in patients with heart failure. But in any case, the evidence for the ARBs is much less than the one on ACE inhibitors. And of course, if you have to start an ARB, then you can start with the sacubitril valsartan.
Thank you, Giuseppe. Ricky, did you have something that you wanted to say?
Yeah, I think Professor Rosano had already explained it very well. We probably start with the ARNI or the ACE first. And of course, if the patient cannot seem to be on these medicines, whether by access or by some other reason, tolerability or what, then the ARB will be the third in the line of choices here.
Thank you. I just wanted to mention, I think Professor Rosano alluded to Asia having a high incidence of cough. I think it's reported as high as sometimes 20% in some of our Asian populations. I have seen also locally that we are too fast to stop the ACE inhibitor just by a little bit of cough, right? And I think the difficulty sometimes is trying to assess whether the cough is due to fluid overload as well, or is it just due to ACE inhibitor? Sometimes this just micro types of fluid overload can also present like a dry cough because it's not like florid kind of a fluid overload. So I do sometimes tell the patients, particularly if their cough is not too bothersome, I tell them, oh, you know, ACE inhibitors are actually working for you. That's why you're getting the cough. As long as they're not coughing too badly, they won't hate me for it very much. I think there was also another study by the name of Transitions that looked at the starting of ARNI Entresto in the inpatient setting versus the ACE inhibitor. I wondered whether any of the professors on the panel have a comment to make about Transitions.
Yes, I think that both Transition and Pioneer study, there's a significant proportion of patients that start with ARNI. For Paragon, they start with ARNI in hospital setting, and for Transition, they also start ARNI in a significant proportion of patients, and they found that ARNI still have a significant effect, the beneficial effect on the patient without increasing significant risk. And this is what they try to implicate to us, that we may start with ARNI even without start ARNI first. Thank you.
Thank you. So I think Giuseppe is still, I think I'll still go with my ACE first. Just look at his facial expression there.
No, it's the issue is that we have to go with the evidence. The evidence is that we have only one trial in a selected population that shows efficacy. The other two trials were not designed for mortality and morbidity. They were designed, the first one for BMP, the second one to compare the in-hospital initiation versus the outpatients initiation. So we cannot draw any conclusion on the efficacy from those trials. I mean, it's safe to use. So in patients, as I said in my conclusion, if you have a patient who is already on an ACE and is in hospital, then switch it. You can safely switch it immediately to sacubitril valsartan.
Thank you. Janice, back to you for the case.
Yeah. Thank you for the professor for the interesting discussions. So now I would like to move on to our second case. Second case is a Mr. Y.A.J. He's 85 years old. He has a known case of hypertension and was previously on the tablet atenolol 100 milligram once daily. He was an ex-smoker who he has stopped for more than 20 years ago. So he has a sudden onset of shortness of breath with audible wheezing. That's why he was sent to the emergency department, where in the ED, he has tachypneic, and he was put on CPAP and later on was able to wean down to ventral mass 60%. And from his lung examination, he has generalized bronchi. That's why he was given MDI salbutamol 10-path stat. And at the same time, he has bilateral pedal edema up to knee. And that's why in ED, they were given IV furosemide 40 milligram step. So some of the investigation has done and shows that actually he has ejection fraction more than 55%. However, his LA was moderately dilated and his NT-proBNP was greatly raised. And from his chest X-ray, he has gross cardiomegaly, and from his ECG, he has AF. That could be explaining why his LA was dilated. And from his blood result, it's nothing remarkable. His creatinine was fine, and his blood pressure was considered normal. However, his heart rate was a bit on the higher side. So he was diagnosed with infective ACOAD and heart failure with preserved ejection fraction and atrial fibrillations. He was then discharged with respimethyl 5 microgram once daily, MDBI salbutamol 200 microgram PRN, tablet apixaban 2.5 mg BD, the tablet digoxin 0.0625 mg once daily, tablet furosemide 40 milligram once daily, and augmentin tablet 625 milligram 3 times daily. So for this case, basically the patient was diagnosed with preserved EF. And that could be the reason why he was not on any, so I would like to ask the panelists and our speakers, how would this patient's treatment plans to be optimized? Anyone would like to take on?
I think we'll want to go first.
Let's see. What is the ejection fraction again?
So the ejection fraction is more than 55%.
Yes. And what is his current medication?
His current medication, as if he's focused or targeting a heart failure, I would say just the furosemide, because the digoxin was for the AF. He was not on beta blocker, likely because they were more concerned of the audible wheezing, so they tried to put him on digoxin first. Yeah, so basically, if he's targeting his heart failure medication, I would say, unfortunately, none.
Yeah. So this patient belong to the group with heart failure, preserved ejection fraction or mildly reduced ejection fraction. In the guidelines say that this group of patients, diuretic should be given for relief congestion. We should investigate for possible cause of heart failure, especially coronary artery disease. We have to focus that his atrial fibrillation is already under control or not. In terms of heart failure medication, as Professor Rosano mentioned that there's an option of treatment for this group of patients, but usually medication belong to class 2B medication, including ARB, mineralocorticoid receptor antagonist, and also ARNI. So this patient, it depends on this patient should be suitable for any of these medication. His creatinine clearance should be acceptable or not. We may start with one of these options and follow the response and follow up for creatinine clearance and potassium level. So this should be the possible option for. So the medication, if you look at the response graph by ejection fraction, you will see that the response graph for clinical outcome of ARB of ARNI, the response will slightly decrease as the ejection fraction going up. Therefore, the approved indication for ARNI in this group of patients is for patients with ejection fraction below normal, as Professor Rosano mentioned during his lecture, that the clinical trial is the primary outcome is negative if you look at the p-value, but sometimes if you look into the detail, you see that the hazard ratio and 95% confidence interval still more toward significant difference as far as the ejection fraction is below median. That Professor Rosano mentioned that the ejection fraction lower than 57, something like that. That's what FDA also concerned as little evidence for approved indication, and this has been also applied to some other countries. In Thailand, we also have FDA approved for this indication as well. But we have to consider other point that I mentioned earlier, looking for cause of heart failure, enough investigation for coronary artery disease, enough control of rate control in atrial fibrillation, and so on. Thank you.
Thank you, Professor Rungroj. I thought that was a fantastic review as well. I think Professor Rosano also talked about earlier the subgroup analysis with Paragon, and indeed pointed out the subgroup analysis showed that the group of people with EF less than 57 and also the female population appear to benefit from Entresto more than the male population as well. With respect to that particular question that was posed, there was another question that was posed with respect to the panel's opinion about basically using sacubitril valsartan in the preserved EF versus the reduced EF population versus the SGLT2 inhibitor. I wondered whether either Professor Tiongco or Professor Rosano, did you have a comment to make about that?
You first.
Okay. Thank you, Professor Rosano, for giving me the chance. Here, actually, I sort of understand what the predicament here is, and I feel for Professor Rosano's point that if it's a negative or neutral study, it's hard to draw conclusions. And if this subgroup of less than 57% proved to show that there's a 27% relative risk reduction in the events, it might actually be more hypothesis generating than proof, but definitely not proof of absence. Perhaps is because if you look at the absolute risk reduction of this group of patients, less than 57%, they seem to reduce relatively similarly the number of events for hospitalization compared to that for the paradigm. Comparing the Paragon results from that for the Paragon less than 57%. So I think that's probably the reason why, despite the obvious statistical facts, that there's a 2B indication for this drug, and it was viewed as that. So we might not all be agreeing on that point, but apparently there's some treatment effect for that, which might need further validation in probably a special subset of patients with that type of phenotype. But in terms of all comers for heart failure with preserved ejection fraction, ARNIs might be a little bit more limited. So Professor Rosano actually a while ago said that these patients might actually more generally be benefit from a SGLT2 inhibitor for across this spectrum. But ACE inhibitors or ARBs probably in some countries with little access or difficult access for ARNI actually might be actually a suitable choice for these patients who could not afford or get with an ARNI nowadays.
Thank you, Dr. Tiongco.
I think in any case, the SGLT2 inhibitors are cheaper than ARNI, so it's in any case it's and the evidence with the SGLT2 inhibitors is overwhelming. I mean, we have 2 trials are very positive with a consistent effect across the left ventricular function. Then regarding sacubitril valsartan, the study was negative. I mean, for many years, we have heard the paradigm HF investigators saying there's a P with so many zeros, very, very significant. So if we go with statistics, the P for Paragon was negative, and so the sub-analysis cannot be done because you cannot perform a sub-analysis in a negative trial. That is, as we've heard, just is a hypothesis generating, but does not give evidence. The evidence here is that we need to give an SGLT2 inhibitor. Also, the evidence is that in these patients are COPD, so they should receive a LAMA-LABA rather than a LAMA and salbutamol, because that may increase risk of events. And also, in patients with COPD, we know that the beta blockers reduce significantly mortality, so regardless of the left ventricular function. And therefore, for these patients, I think that there's a clear indication for nebivolol that preserves the bronchodilation of LAMA-LABAs.
Thank you, Professor Rosano. I think there was also some sort of a cohort study that showed that the bisoprolol is actually also pretty safe in a COPD patient, particularly if they're well controlled. And if we stop bisoprolol in that population, people tend to do worse with respect to the heart failures as well. And so I think that's an important reminder from Professor Rosano that we should not hold off beta blockers just because people have got airway diseases. But it's fairly important for us to control the airway disease as well, so that we could still give our patients this evidence-based medication for the heart failure. There was another question by someone on the reduced EF population following a myocardial infarction. And this person wanted the panel to comment on the SGLT2 inhibitor or whether the ARNI is going to be more effective for a person like that. And I believe this person is asking mainly because most of our studies that we have all these fantastic results for were in people with the NYHA functional classes of 2 to 3 or sometimes 4. And I believe this person is asking in the context of someone with a reduced ejection fraction just following an MI and potentially not yet in a congestive state, maybe like a stage B kind of a patient. I wonder what the panel has to say about that.
I have some comment on this. For post-MI patient, if the patient is symptomatic reduce, it is not of the question. This medication is indicated. It will be in the stage B with patient not symptomatic. This is also there's lack of evidence. There's a limited evidence or supporting the use of this drug. For as Professor Rosano mentioned, that there's a trial called Paradise. That is also a negative trial for post-MI using ARNI. But in the hotline of ESC this year, there's a reanalysis of Paradise using win ratio method, and it showed positive results. And this article is just published in European Journal of Heart Failure. I think there's a kind of analysis method that may influence the main result of the trial. There's some possible benefit that may not be positive in the initial analysis. This is for ARNI. For SGLT2 inhibitor, also similar. If you have still stage B, there's still a little lack of evidence to support the use. But I think that in general, it should be benefit in this group as well. But there's no it's ongoing trial that to answer this question. Thank you.
I think
Thank you.
evidence.
Anyone else?
I think that the evidence with the ACE inhibitors is overwhelming, and it's not just in the consensus patients, but it's also in AIR, TRACE, and Europa. All of them show the benefit of the ACE inhibitors in these patients, and so they should be first line together with the MRAs, because it's FSUs also show the efficacy. So then you can discuss on and you can twist the results of negative trials, reanalyzing them. But at the end, you have to stick with the primary endpoint. And if there's any difference in benefit, probably that is not justified by the increased costs. So I think that is something we have to also to take into account, and therefore these patients should be using an ACE inhibitor first.
Thank you. Dr. Tiongco, did you have comments?
Yes, I think the Paradise results were generally clear in terms of the neutrality or the negative results. Maybe the sub-analysis or the analysis that Professor Rongkong has presented a while ago would be probably promising in the light of newer data. But I think Professor Rosano already clarified here that the wealth of data supporting the use of ACE inhibitors more than ARBs, for example, over the past how many years would show consistent benefit and the recommendation for ACE inhibitors post-MI.
Thank you.
What is the beta blocker is also indicated as well in this stage B post-MI.
Thank you.
Yes,
thank you for the big reminder. Yep.
If there is left ventricular dysfunction, if there is left ventricular dysfunction, because we have to remember that above 50%, beta blocker has not been shown to reduce mortality and morbidity.
Yep. So to summarize, the evidence-based medicine for the post-MI population with reduced EF, which is assumed to be less than 40, we should be giving our patients the ACE inhibitor, the MRA, and also a beta blocker. For those who are above 40, the beta blocker's role is not as clear as it was several years ago. Let me just pose the last two questions to the panel. And one of them is about subgroup of the mitral regurgitation patients. And this person is asking about the study called the PROOF-HF study, whereby the ARNI showed efficacy in the MR patients and reduced EF. Should ARNI be the first choice for this group? And the second question on the sacubitril valsartan for the use of resistant hypertension without heart failure. Did the panel have comments about both?
Yeah, I mean, the study was just presented at the HFSA, and basically they showed that if you start directly an ARNI, you reduce it, but that is the same effect that has been shown in the past with ACE inhibitors. So I wouldn't prefer that just because of the MR. So that is my point, and that was we always have to put the results of the studies in perspective and see who they are compared with and whether those patients were already on a medication. What was the other question?
The use of ARNIs in resistant hypertension.
I mean, resistant hypertension is interesting because that is specific, especially in those with resistant hypertension and preserved ejection fraction. That can be a very good option for the ARNI.
Thank you. Dr. Tiongco or Dr. Rungroj?
Yeah, no, I agree with Dr. Rosano. Please.
No further comments.
I think these questions, professors, are relatively in the line of little evidence, but these are very promising fields or situations where we might want to see added benefit for ARNI and resistant hypertension. But I'd probably see this value just in case all the other pharmacotherapies have been lost. I cannot see how we can justify the added cost at this time. But if the patient actually has reached that point wherein pharmacotherapy leads that way, it's not impossible to consider the ARNI for that patient, but not a very common strategy nowadays, but promising in the light of us waiting for the data. For the PROOF-HF, I think the positive remodeling for the ARNI in the slide might actually reduce the functional MR if that's the point. But I think in terms of larger subsets of data, we would like to see more of this, not probably universal for all MRs.
Thank you. Okay, I think it remains for me to summarize what we have learned today. I think we talked a little bit about the clinical trials and how the p-value is important in respect to the interpretation of studies. And I think we just want to go back to the basics that the p-value basically tells you how likely you are correct when you make an assumption for your null hypothesis. And therefore, there's a split opinion about whether an ARNI should be used in people with just that slightly reduced ejection fraction. In some of our countries, the ARNI is actually labeled for that indication beyond the reduced EF population. So the second thing that we learned today is basically on the comparison between the SGLT2 inhibitors as well as the ARNI with respect to the spectrum of the different types of EF in different types of heart failure patients. And I don't think that we should be having this exercise of competition between the SGLT2 inhibitors and Entresto, but I think it's far more important for us to think about who should be deserving of these agents based on the clinical risk factors, rather than try to compare them here and there. Because in the population with the reduced EF, we're quite clear that all these agents are needed anyway, and it's just a matter of when we start them. Maybe the population with the slightly reduced EF, well, we are a bit more cautious. And with the subgroup analysis or smaller group analysis with the MR and everything else, I think we can maybe keep our eye on that space in order to see how the ARNIs will actually evolve from there. All right, and so it remains for me to give Janice back the time to close on a couple of announcements from the ISCP. We thank the audience for attending this evening and the great questions that you've given to us. Janice?
Thank you, Doreen. And once again, I would like to thank to our fantastic faculties today for their fantastic contribution. Thank you, Professor Rosano. Thank you, Dr. Tiongco, and thank you, Professor Rungroj. So before we say goodbye, so I would like to have some shout out or some announcements. So I do encourage all the audience to join the family of ISCP. If you join the membership, you can enjoy some of the benefit as below, like you have electronic access to the journals, can access to the ISCP website and on-demand contents. You can even get up to 50% reduction on registration fee for the annual congress, and you will be eligible to participate in speakers panels at the ISCP meetings. Next, I would like to also remind or give a shout out also to our 27th International Society of Cardiovascular Pharmacotherapy Annual Scientific Meeting, which is happening in Romania from 27 to 29 October 2022. And to be on note that is that you can participate. This is either online or on site. So it's a hybrid activity, or yeah. So for those who are a member, if you are a member of ISCP, you actually can join this for free. So I do encourage all of you to join us either online or on site. So I believe there will be a very fantastic topics will be discussed and shared during the meeting. Last but not least, I would like to remind you all to save the date for our next webinar in the A to Z series with the title Clopidogrel or Ticagrelor, Why, When, and For Who, which are happening in 7 December 2022. Last but not least, I would like to remind that this event is CME accredited, so please don't forget to submit your details to claim your certificates. And today's proceeding will be very shortly be available on demand at the Redcliffe website. So do go there to watch again. So I think that's all from us today. Goodbye.
Goodbye. Thank you, everyone, the panel speakers, and everyone for attending. Till we meet again.